Well, welcome to this Pharmacology drug class review on the category of anti-diabetic drugs with a specific focus on the SGLT2 inhibitors. Now, this drug class has been huge for us as clinicians in the management of type 2 diabetes, but in patients who also need cardiovascular risk reduction, who have CKD or heart failure. This clearly makes these agents useful when a patient is obviously suffering from more than one of these comorbidities. And with that, I'm Dr. Busti. Thank you so much for joining me on This Is Why and show dedicated to helping us as healthcare professionals understand the why behind the decisions that we make every day. And that includes pharmacology and the drugs that we use. When we understand why, it makes the how easier. And that includes just understanding mechanisms that help predict those therapeutic effects. But in this case, we're going to see it also helps us understand side effects, monitoring parameters, and counseling points. All right, so with all my drug class reviews that I cover, I hit on all the core content, things that sometimes you have to memorize, the facts, right? They are what they are. That's our agents, indications, uses, net benefit, why choose this drug over something else. We dive a little bit into the pharmacology. This one's pretty interesting. It's fascinating, a unique perspective on how to get patients' glucose under control. And then we'll kind of migrate over to some clinical pearls, things you need to think about, warnings and those kind of stuff that show up in everyday clinical practice or are related to things that we should document. All right, we're going to move now to the agents, and this class has grown over the past several years, and so it's going to probably continue to evolve. And just as a reminder, drugs classes that see expansion and growth, usually it means because there's money to be made, but that's also correlated to it's needed, right? There's benefit, there's evidence, and it ends up being patient specific and helps us as clinicians manage multiple comorbidities at one time. That's great, okay? Now, the SGLT2 stands for sodium glucose cotransporter inhibitors, okay? You see they all have a common ending, gliflozin, right? So we have Bexagliflozin, Canagliflozin, Dapagliflozin. Right? So it's an easy way to kind of recognize and remember them in that way. I did want to point out the last one here, the Sotagliflozin. That was an SGLT2 inhibitor, but it's also an SGLT1 inhibitor, and that's unique compared to the other ones at some degree, especially based on its indications. All right, now we're going to migrate over to what are the most common uses and indications in clinical practice. And when I refer to this, I'm not always talking about what is FDA approved only, but where does the trend and the movement occur? And we're going to see, I think, things continue to evolve and shift. So I have a table that I put together for you that helps to kind of consolidate the big picture, okay? Knowing that things change, update, grow, expand. So that's just the reality of what we learn as we go, right? But when you have the foundation and you understand, it sort of makes sense. So the point of this table, which is available for you at thisiswhy.health for anybody that's interested, for using it for studying, sharing with friends, colleagues, you know, if you teach or faculty preceptor and you want to use it, fine. That was the goal for it, right? It helps me to wrap my own brain around especially a class of drugs that is growing. And so these are things that sometimes when you memorize them, then we can start building on them and you can start to apply it when you are in clinicals or rotations or when you're starting to manage patients or you're already doing that yourself and you start seeing these drugs. You know, I practice in the emergency department. Well, I see these drugs. I don't start them, but I see them all the time. I'm seeing more and more patients show up on them. Why? Because look at all these comorbidities that we can treat. Type 2 diabetes, cardiovascular risk reduction in patients with diabetes, heart failure, CKD. Yes, the majority of these drugs are being used for type 2 diabetes. The Sotagliflozin is the one that's the exception, but I wouldn't be surprised if it does. You know, this is kind of a little bit in lines like the ACE inhibitors where, you know, you get some evidence in a couple of the drugs, they show a consistent pattern of effect. And that sort of gets extrapolated and people start using it off-label. That's where common uses sort of evolve. I'm not saying it makes it all right or perfect. I'm not even saying it's evidence-based. But the reality is that stuff does happen. Now we need to pay attention to the movement. But what you see here with heart failure, there's quite a number of options that are drugs that also are used for heart failure. CKD, same thing. So you start to see a pattern and a story of things being put together with a similar overall safety profile. So I try to provide you the generic name, brand name, and then the various indications as we know them, but recognizing that that will continue to flex and probably grow, and there's nothing wrong with that if those companies should choose to seek out additional evidence for that. All right, now we're going to pivot over to the net benefit. Why pick this drug class over something else in your bucket of tools that you can use to manage patients with type 2 diabetes? So the net benefit is that we're going to decrease glucose, but it's a unique mechanism, and we're going to see that here in a minute when I dive into the pharmacology. It impairs the reabsorption of glucose in a glucose-dependent manner. So the higher the glucose that we have, the more it's going to inhibit the reabsorption of that in the kidney, and it's specifically the proximal renal tubule. But what's that benefit? Well, it lowers the blood glucose levels because our kidneys would normally reabsorb it and put it back into the body at certain thresholds, up to a certain threshold. And so we will decrease glucose without affecting the pancreas, without affecting insulin. That's great. So we're not causing the disease to progress like secretagogues would do, right? We're not causing significant weight gain because we're not causing anything to happen with insulin in particular. The risk of hypoglycemia is low because this is an effect that's glucose dependent, right? And we get rid of extra fluids. And so if patients with other comorbidities where they have fluid volume management problems, this is where it can be very helpful. Okay, now we're going to pivot over and dive a little bit more into the details of that mechanism that I just started talking about. So when we think about SGLT2 inhibitors, they inhibit the filtered glucose that makes it into the proximal renal tubule. We prevent it from being reabsorbed. Now, in normal physiology, okay, our kidneys are helping to regulate electrolytes and fluid and glucose and things like that, and we want to get rid of waste products that are not supposed to be there. And so there are compensatory mechanisms where the body will reabsorb things that it put in there initially. So just think of it as a big filtering membrane, like, system, which is what dialysis is trying to mimic. Take off what is needed, put back and keep what is not, right? That should go back in. And so that's that balance. But when we look at the proximal renal tubule, 90% of most of the glucose that we filter in there gets reabsorbed. The problem is in patients with type 2 diabetes where that exceeds the threshold of the kidney. Then it starts to spill that glucose into the urine, which is why we see glucose in the urine in patients with uncontrolled diabetes. And so we're going to predominantly impact that, and specifically the SGLT2 receptors. Now remember, Sotagliflozin has SGLT2 or SGLT1 inhibition, and that's in the intestinal glucose absorption, sodium reabsorption, that offers that unique benefit. Now, when we think about where this is happening, let's just take the high-level picture of the kidney in a cross-section. So this is one of your kidneys, cross-section. You see blood vessels coming in and out. So there's perfusion going into these nephrons, and then there's the return of blood out, the venous blood, back into central circulation. Of course, the kidneys also have nerves and things, and then whatever makes it into the urine filtrate eventually will empty into the ureter, down into the bladder, and be eliminated. So we are going to zoom in into this area right here, and that's where we have our nephrons. So here we are, we have the renal afferent arteriole coming in to the glomerulus, and then it exits out. So we have this peritubular network that's going around the components of the nephron, facilitating exchange between water and reabsorption of water and electrolytes and other things. And so let's zoom in right here because this is where the SGLT2 inhibitors are primarily working. So zooming in, we see that we have the glomerulus here, and there's Bowman's space, which is the very beginning portion of that proximal renal tubule. We have blood flow coming in through the renal afferent arteriole. That then applies a direct pressure called the glomerular filtration pressure exerted on that basement membrane and pushes things over and filters it into Bowman space. But then the blood flow leaves and goes through the efferent arteriole and then down the peritubular network that, again, continues to facilitate exchange. And that's where we need to zoom in at this level. So the glucose gets in, and now it's moving down the proximal renal tubule. And this is a very complicated looking diagram that I put together for you, but these are the early proximal renal cells. This side over here is the luminal side, and this is the basolateral membrane, and the side over here with the basolateral membrane and the blood, where there's that other exchange. And you see there's a lot of transporters and things going on. In fact, this is not even all of it. It's not meant to be all of it. It's just a representation of some of the key transporters that are going on in that area. But you see that glucose over here can be reabsorbed through the GLUT2 transporter on the basolateral side. So that filtered glucose comes in, right, along with other things. And then there's all this exchange going on to try to keep it balanced. But one of the things that you see here is the sodium glucose transporter, cotransporter 2 right here. That's where 97% of the filtered glucose is going to be reabsorbed. Well, once it gets in here, then it moves across and gets put back into the blood up to a threshold. And that's around 180 milligrams per deciliter of blood glucose. Now you see that SGLT1 receptors are present later down in the proximal renal tubular cells, but they're less involved. So we have specificity to the transporter that right there where we're inhibiting it. So it works on the apical membrane and the luminal side to block the reabsorption of that glucose that was filtered. And so the higher the glucose that's in your blood, the higher the concentrations that make it in the lumen, the higher the concentrations that make it in the lumen, the higher the concentrations that will go down and be part of the urine filtrate in the rest of the neuron and eventually make it into the urine. That becomes very important in understanding why patients can lose fluid, because what follows glucose? Water. So these patients start to diurese. So they're almost like diuretics in a sense, right? That's why they can be helpful in heart failure. It makes sense why it helps those patients with fluid volume management. But you also are, the higher your glucose levels are, and the more uncontrolled you are, the greater the concentration of glucose present in the urine filtrate. Okay, why does that matter? Well, because glucose present there, it sets up the opportunity for microorganisms to flourish, and particularly yeast, Candida, and those kind of species. So yeast infections become a big problem in these patients. And we typically don't want patients with diabetes suffering from or developing infections. In fact, we do everything we can to try to prevent them. And so there are some complications that can develop that I'll mention that has gotten some history over course of time. All right, I know that was a little bit more detail and a lot, but I hope that made sense of where these drugs are working and how they work. And I hope it starts to make sense. I'm leading you in that direction of why it translates to understanding side effects and then your monitoring parameters and your counseling points, okay? All right, now we're going to step into clinical application and knowledge. And I'm going to start out first talking about the big picture, okay? So I put together tables for you. These are available for free download at thisiswhy.health. You're welcome to use them for studying, share them with your friends. Again, they're free. The link to this episode is available in the description of the video that you're watching if you're on YouTube, or if you're on our podcast channels, it's in the description available to you at Spotify and Amazon and Apple and those places that we have our show. Now, this table is meant to just be a generic overview of the approach to management. So type 1 patients obviously need insulin plus or minus pramlintide, and this is in conjunction with medical nutrition therapy and exercise, of course. Type 2 patients, which is where we are focused, Yes, you have medical nutrition therapy, you have exercise, but remember this first bullet is monotherapy or combination therapy with a non-insulin based treatment. Why? Because we don't want to facilitate weight gain. We aren't looking for risk of hypoglycemia. We would rather use drugs that don't cause weight gain, don't cause the progression of the disease, that cause us to lose a little bit of weight and other comorbidities. That's a win-win. The SGLT2 inhibitors fit in this particular bullet and bucket, okay? Now, do they always get patients to control? No, but they're still fit in that bucket. Now, when we talk about non-insulin agents in that first bullet, you're talking about secretagogues and non-secretagogues. Well, the secretagogues are meglitinides and sulfonylureas that facilitate the release and concentrations of insulin present, which can cause weight gain, risk of hypoglycemia, okay? And they can cause progression of the disease. Whereas the SGLT2 inhibitors, they fit in the non-secretagogue, non-insulin based options, which is where you see the majority of the growth. So this table here screams that this is the focus on how we should be managing patients with type 2 diabetes. We really have moved away from the focus being on drugs that would increase the release of insulin that historically has been used, the sulfonylureas, which there's good history, there's good evidence, but unfortunately the A1C reductions are not sustained. And the risk of hypoglycemia is there, and the risk of weight gain is there. These drugs have been targeting those things and without progressing the disease. So these are huge and offer value in that perspective, especially as we've acquired evidence over the years to support that, right? Because we should be evidence-based clinicians applying evidence-based decisions for our patients so that we know why we're doing what we're doing. And so you see alpha glucosidase inhibitors, even though it's not used very much, amylin analogs, biguanides, DPP4 inhibitors, GLP-1 receptor agonists. And then down here is our group that we're talking about, the SGLT2 inhibitors. I give you their main mechanism so you can compare them to other mechanisms and learn drugs and drug categories in the context of each other. And it makes sense. And then what are those classic agents, knowing some come and go, and also this will continue to potentially evolve. Now, what about comorbidities, where I should consider them, where I should avoid them? We should think like that at a big picture, high level, okay? High level. I'm not saying in all patients. This is not an absolute. It is a guide to help remind you, wait a minute, should I stop? Or should I be using this drug class? Or why am I not using this drug class? Or why is this patient I'm seeing not on this medicine? And they should be, right? Those are the kind of thinking and thoughts that you want to kind of go through as a clinician so that you apply the best treatments to your patient. But also for board exams, these become very relevant. All right, so on the first column on the left, you see that there's the medical condition: obesity, overweight, dyslipidemia. Does the patient have CKD, heart failure, CAD, cardiovascular disease, gastroparesis, irritable bowel syndrome, pancreatitis, osteoporosis, and then down there is the cancer of the thyroid that's mainly affected by the incretins, the GLP-1 receptor agonist. Okay, when should we consider the use of SGLT2 inhibitors in these comorbidities? Well, right here you see SGLT2 inhibitors to be considered in patients who are overweight, obese. Help that water, you're going to lose some weight, mostly water weight, but it's still helpful. Renal kidney disease, plus or minus there again. We don't want to over-diurese the patient, right? We don't want to lose too much fluid because that could cause acute kidney injury, a pre-renal azotemic pattern. What about heart failure? Absolutely, especially those patients with heart failure with reduced EF and they have typically fluid volume problems. Excellent, especially if you have coexisting type 2 diabetes. What if you have coronary artery disease or atherosclerotic cardiovascular disease? Yeah. So you see SGLT2 inhibitors in my table where, again, I'm trying the big picture of where you should consider them. That's a lot. That's very relevant. Now there's other drugs too that need to be considered. I'm not saying it's only these. So I have no interest. I have no special conflict of interest. I don't own stocks in drugs. I don't do that. I don't talk for drug companies, right? But I recognize when we have evidence-based treatment options that we should consider them. However, I also recognize that sometimes things get too much attention and we miss some of the other issues associated with these drugs. And I have concerns about this drug class too. So I'm praising it a little bit, but I'm also going to beat it up a little bit, okay? And so that's where the avoid column over here on the far right. And you see that it says plus or minus, avoid them in renal disease. Why? Again, over-diuresis could cause acute kidney injury, especially in patients who are already having issues with dehydration. What about risk of euglycemic DKA? Yep, that shows up. Osteoporosis and fractures. Yep, that shows up, right? I should even put in here like yeast infections. Yep. You have recurrent UTIs, recurrent pelvic infections. Yeah, not a good idea. Okay, so just keep that in mind. That's the big picture, okay? Codifying that a little bit more, right? So independent of metformin or the A1C, these patients who have underlying vascular disease, chronic kidney disease, heart failure, you really should give these consideration because of that evolution of evidence. Now, that doesn't ignore the other evidence-based drugs that we have on the market for those conditions, right? Statins, lipid-lowering drugs, some of the mineralocorticoid receptor antagonists, all these. You shouldn't ignore those drugs, okay? But just, again, when you have multiple comorbidities and you can treat both with one or limit the number of agents that someone's on, that's always a good consideration. They lower the A1C by approximately 1%. So you're like, well, okay. I mean, is that good? Well, sulfonylureas could do it by 2%. Metformin can do it to 2%. So what does that tell you about this? Yeah, interesting mechanism, beneficial effects with other comorbidities, evidence to support their use, some FDA-approved indications that are evolving, all good, check, 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 check. But if your patient's got a A1C of 9.5, 10, 11, you're not going to get them to goal. These patients need combination therapy, which goes back to that table that I have for you, where it's monotherapy or combination. Very few people are on monotherapy. Okay? Most patients with diabetes, especially type 2, are on combination therapy. And so that's part of the reason is that you need more than just this. Now, the risk of hypoglycemia is lower. Remember, it's causing the glucose to be impair glucose reabsorption in the kidney in a glucose-dependent manner. So there's a certain, threshold that you're not going to prevent all glucose reabsorption, right? But you're not facilitating any insulin secretion or release like the secretagogues. You're going to see a weight loss. Most of that weight loss is water and from fluid changes, okay? So just keep that in mind. Morning administration is preferred simply because of the postprandial effects that occur throughout the day. So we eat most of our meals, and so our thresholds of exceeding that glucose that we need is going to be higher during that time, and so we should be trying to dose it in the context of that. Sotagliflozin also should be administered 1 hour within the hour of the first day's meal. Again, it's working in that GI tract as well on SGLT2 in addition to the others. Now, surgical and endoscopy-related procedures, where we get concerned about surgery and procedures that are more invasive, is fluid balance issues and glucose homeostasis issues. One of the problems with this drug is that it can cause so much glucose to be released into the urine because of blocking it. The patients can have a hidden sort of deceptive normal glucose but have DKA. They can also have acute kidney injury because of too much fluid loss. And when sometimes patients are NPO, nothing by mouth, going into a procedure, they're not bringing in the volume to keep those kidneys perfused. And so we just need to be cognizant of those conditions so that these patients don't develop hypotension. Now, going back to the infection, remember when you block the reabsorption of glucose and it spills into the urine filtrate, water follows it, so you diurese, you pee, right, or micture. That changes the concentration of the urine. And so patients are obviously with diabetes are at greater risk for yeast infections and other antimicrobial infections. So we need to keep that in mind. And so mycotic infections are much greater than bacterial infections, but they're still relevant. Okay? In fact, there have even been cases of Fournier's gangrene that's rare, but remember, rare doesn't mean irrelevant or ignore. I have seen multiple cases of Fournier's gangrene, and you can smell it before you ever enter the room, right? I mean, it is just tissue that is dying, literally, at a rapid pace. And these patients within hours could be dead. Requires emergent surgery. And so where does the Fournier's typically happen? In the perineal area. Dark, moist. You know, if you're overweight, that tissue does not get perfused, high risk for infection to spread. And I mean, this is one of the worst kind of infections you will ever see in your life. Okay? And so again, I'm not saying it's going to happen. It is rare, but it is clearly life-threatening. And so if someone comes in with pelvic pains, redness, swelling, and you have a patient with that's diabetes, you should, you know, I mean, we have to take a look, right? And because you palpate and you feel crepitus and that tissue is very tender and is spreading rapidly and they're saying, I'm getting worse, man, I'm telling you, you'll never forget it, okay? You'll never forget it. Now, obviously, if you're diuresing somebody, you know, from diuretics or drugs like this, you can cause hypotension, right? You reduce the preload in patients, they get up, they change positions, they can get lightheaded and dizzy, orthostatic. That's very possible, especially in our older patients, okay? Patients with other antihypertensive medications already on board, right? They already sit in a lower systolic, right? Maybe they have reduced oral intake for whatever reason going on around a procedure. So don't forget about this, especially in our older patients. Now, I mentioned DKA, and it's not like the same type of DKA as in type 1, type 2 in this, patients, especially type 1s, where they have usually higher glucose levels, closer in the 250 to 500 milligrams per deciliter range. These patients can have a normal glucose, so it's euglycemic, DKA. So they're still spilling ketones in the urine. You see an anti-gap metabolic acidosis on their labs. It is really weird. It's deceiving. It almost looks like an alcoholic ketoacidosis follows a similar pattern. So it creates a lot of confusion. So when you get a basic metabolic profile or CMP and you see an anion gap, you have a urinalysis shows ketones and the patient doesn't look right, and something's not lining up, don't just interpret the glucose, oh, it's normal, this couldn't be DKA. That is the mistake, and these are showing up more and more on board exams, and so you need to keep that in mind. What about fractures? I listed that on that table, right? Canagliflozin had been shown to increase risk of fractures. Other drugs and studies and things have not always shown that to extrapolate to other groups. Well, when one drug starts to find the problem, then when you do a clinical trial on new drugs coming out, guess what? The researchers are very meticulous about not including certain people because they don't want, and doing certain things because they don't want to create also the problem, right? And make it show up. But the reality is there's some signal going on there. And so if you have a patient with underlying osteopenia, osteoporosis, please just keep that in mind, okay? Now, amputation risk. You're like, what? So you see why I was like, yeah, it's got some cool mechanisms, cool benefits, all this stuff, but there are issues with this drug class, okay? And so the same thing here, why would someone lose a limb? Well, one is infection, okay, number one. Number two, and I talked about Fournier's and things like that. Number two is these patients already are at higher risk for vascular disease anyway, okay? So there have been some concerns. So patients with other known histories of peripheral vascular disease, they've had prior amputations, they have old uncorrected or untreated ulcers, right? Bad care. Those are the patients that are at higher risk that should be on your radar. From a drug interaction standpoint, mainly it's going to be those diuretics because you can over-diurese the patient and cause a prerenal azotemia that can lead to acute kidney injury. And so you do want to be careful of other drugs that augment also the activity of the nephron. Things like ACE inhibitors, angiotensin receptor blockers, mineralocorticoid receptors antagonists, even NSAIDs that are known to constrict the blood vessels and cause a interstitial nephritis or acute tubular necrosis because of the reduction in perfusion to the kidneys that can sometimes happen when you give NSAIDs at higher doses when you wipe out those vasodilatory prostaglandins in those areas. And so that becomes very relevant and something that you don't want to ignore. Now, monitoring parameters, you put someone on this drug, well, you're going to get obviously A1C. You're going to get that 1%. You're going to monitor their weight, their vital signs, blood pressure, weights are going to be helpful. Monitor the serum creatinine, make sure they don't tip the other direction, especially if they're using other drugs, which many times they are, because remember, what do they also have with diabetes? Dyslipidemia, hypertension, right? So we're using diuretics or other drugs. So the blood pressure, the serum creatinine, potassium, those things become relevant because they're going to probably be on an ACE inhibitor or an angiotensin receptor blocker because of their diabetes. For their to protect against diabetes, nephropathy, and things like that, right? So we want these patients to be on the appropriate drugs, but when you start mixing them, you can create the perfect milieu, an environment and situation that tips them into the wrong direction. From a DKA standpoint, again, you're looking at a basic metabolic profile or a comprehensive metabolic profile that would show you an anion gap, right? Drops in bicarb. You would see ketones in the urine. You could certainly measure the ketones in the blood, but those would be the pattern that most people see initially or up front. All right, what about the use of these drugs in special populations like pediatric patients? Yes, you can consider those in patients around 10 years and older with type 2 diabetes, especially if they have some of those comorbidities already developing. Geriatrics, be careful with them in these patients. Why? Because remember, they're on multiple medications already, and these patients suffer from risk of easy side effects that would cause dizziness, lightheadedness, orthostasis, and they're already on many times drugs like anticoagulants, antiplatelet drugs. They already have osteopenia, osteoporosis. And so if they fall, not only can they get a fracture that we talked about with these drugs, but they can also get a head injury. And if they're on antiplatelets or anticoagulants at the time of that, that could precipitate an intracranial bleed, all because of the use of a drug in the wrong patient population. And then lastly, in geriatric patients that cause confusion is infection. I have patients present to the emergency department all the time from the nursing home with altered mental status, and they commonly have urinary tract infections, and many times they have mycotic infections because they aren't getting turned, they sit in diapers all day long, whatever, people neglect, all these things that can happen. So pay attention. There are pros and cons to this drug class. So the SGLT2 inhibitors, to wrap things up, are very important and relevant to the arsenal of options to treat diabetes, especially type 2. And you have comorbidities like heart failure, CKD, right? These can be helped with that because that unique mechanism of working on the luminal side in that proximal renal tubule to block the reabsorption of that glucose back into the blood. So you're going to spill it in the urine. And initially, especially with higher concentrations and uncontrolled diabetes, the risk of mycotic infection is going to be higher. That risk goes down after you get the glucose under control because you're not spilling as much glucose into the urine, right? But pay attention to that. Risk of fractures, risk of the limb issues. Again, not extremely, it's not happening to everybody on them, or we would stop using them. But it is enough of an issue that you should remember that as a clinical pearl, okay? So I hope you found that information to be helpful and put in the context of the overall management of type 2 diabetes. If you haven't done so yet, please be a subscriber and follow us on YouTube and ring the bell, which basically alerts you to when new content comes out, because we'll be continuing to add new topics. Hop over at thisiswhy.health, join, submit a topic for interest. We'll do topics based on feedback that you guys want or question maybe you guys have. We do different categories of topics, disease state reviews, cover anatomy, physiology, radiology, all these different topics, medical rounds, questions. They're there to design to help us to understand why we do what we do, because it makes the how in managing patients so much easier. I'm Dr. Busti. Thank you so much for joining. We'll see you next time.